Nur Atika. Morning, Bu Atika.
Good morning, Dr. Bilal and Prof. Ratna and everyone.
Yeah, okay, thank you. And the next, maybe Bu Inge, the Secretary of Department, also join in this Zoom. Morning, Bu Inge.
Morning, Dr. Ratna. Yeah, morning, Dr. Bilal.
Thank you. Okay, I think it's better if we continue to the main session. So I will give the session to the moderator.
Okay, thank you, before. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Respected mention Professor Dr. Santi Martini, Master of Public Health as the Dean of Faculty of Public Health Universitas Airlangga, Dr. Muhammad Bilal Siddiqui as the guest lecturer today, lecturers, faculty members, and also all of the college students. I'm Hasna Amalia Salsabila, your host today, and I'm delighted to welcome you all to the guest lecture session with the topic Health Service Delivery in Developing Countries and Best Practice. Thanks to Allah the Almighty, and also thanks to the committee for this great opportunity so we can gather in a platform to transfer knowledge and took the chance to learn together as well. Before we walk into the lecture, I'd like to briefly review the schedule for today's agenda. First of all, greeting, national anthem and Airlangga hymn song, introducing the speaker, the guest lecture, discussion and Q&A session, documentation, and closing. So, let us begin by listening to the Indonesian national anthem and Airlangga hymn. For the committee, the time is yours.
Hi, can I start?
Oh, I'm sorry, Dr. Bilal. Before we start the lecture, can we have Indonesian national anthem and Airlangga hymn first, Dr. Bilal?
Right,
Okay.
I'll be waiting.
Okay, thank you.
Thank you.
Dr. Bilal, can you please turn off the share screen?
All right.
Okay, thank you so much.
Indonesia tanah airku, tanah tumpah darahku. Di sanalah ku berdiri, jadi penuh hidupku. Indonesia
Now we are going to listen to Dr. Muji Sulistyawati opening speech. Dr. Muji, the time is yours.
Okay, maybe I just want to introduce our Vice Dean 3, Bu Muji. Can you open your camera? I saw her name is already on the Zoom. Hello, Bu Muji. Okay, Mbak Hasna, Bu Muji just told me that her gadget is in trouble, so maybe the audio is cannot speak the audio. So maybe we can skip this opening speech.
I see. Okay, thank you, Mrs. Ratna. Okay, next. Now we're moving on to the next agenda. Today we will learn about health service delivery in developing countries and the best practice of it. This great topic will be delivered with an expert, Dr. Muhammad Bilal Siddiqui. Good morning, Dr. Siddiqui.
Good morning. How are you? And good morning to everyone.
Okay, morning. I'm happy to today. I also fine enough. Dr. Siddiqui, how are you?
I'm fine. Very good. Thank you very much.
Okay, happy to hear that. I'm excited to listen and learn your lecture today. But before the lecture started, I would like to introduce you and your outstanding experiences to the participants. Okay?
Sure.
For the committee, please show Dr. Siddiqui's CV. Okay, Dr. Siddiqui was an assistant professor community medicine and public health Laurel Medical College in Pakistan. He has a distinguished career spanning over 2 decades as lead health system strengthening specialist and child health legal epidemiologist. Dr. Siddiqui has an academic expertise, over 10 years of postgraduate faculty experience in public health, teaching a wide range of modules including health system and policy, research methods, biostatistics, and epidemiology. Dr. Siddiqui proven ability to design, develop, and deliver engaging modules utilizing contemporary teaching technologies, also committed to student success, providing personal mentoring and addressing pedagogical and welfare concerns. In leadership and advocacy, he is the founding CEO of the House of Quantum Networks, a scholarly open access publishing agency. Then he also president of Global Health 360, a leading organization dedicated to advancing global health initiatives. He also executive member of the Canada-Pakistan Research Development Council, fostering research collaboration between the two nations. He also founding member of the National Maternal and Child Health Registry of Pakistan and the Maternal Health Registry of Pakistan, significantly contributing to maternal and child health research, and also actively involved in advocacy through organizations like the Center of Maternal and Child Health Research Division and the Health Advocacy Council for Women and Children. Dr. Siddiqui also has so many research accomplishments. He has extensive experience in designing, supervising, and monitoring public health research projects, particularly in the areas of maternal and child health, social determinant of health, and service delivery. He also well versed in mixed methods research, quantitative and qualitative, implementation research, project management, and grant writing. Proven track record of research publication in prestigious national and international peer-reviewed journals, regularly serve as a peer reviewer for esteemed journals like Asia Pacific Journal of Public Health and BMC Research, PLOS ONE, Global Health, and Curious. Sought after keynote speaker at research conferences, sharing expertise and stimulating discussions. Areas of his expertise were health system strengthening, legal epidemiology, child health epidemiology, child mortality and survival, and also social determinants of health. Wow, it's so amazing, outstanding experiences. Now, without any further delay, let's listen to the precious lecture from Dr. Siddiqui. Dr. Siddiqui, the time is yours.
Thank you very much, Hasna. It's so nice of you for sharing some of my expertise and some of my area of interest. I really in depth of Hasna. Thank you very much again for your good words and kind words. Now, Assalamu alaikum, everyone, and all the participants. I hope you all are in good health. My name is Dr. Mohammad Bilal Siddiqui, and today we are going to discuss. Not actually discuss, but I'm going to deliver a lecture what regarding the health services, health system, and health service delivery in developing countries, and what should be the best practices in improving and strengthening the health system and health service delivery in developing countries. I hope you are getting what I want to say. So basically, we are touching upon two different areas in developing countries. One is health system, and the other one is health service delivery. These two things are slightly linked up with each other. And why are we looking forward for the developing countries, you may ask? Developing countries are those countries which basically, if you talk about Millennium Development Goal, which was initiated in 2000 and with a target to achieve in 1990, some of the countries showed a good result, and they were able to reduce and achieve the target by 2015. However, when we see in the post 2015 era, like after the 2015 time period, we saw that some countries lagged behind and they failed to achieve certain targets suggested and advised and by the Millennium Development Goal. So those countries, majority of them are from Africa and South Asia. If you talk about maternal and child health specifically, countries like India, Pakistan, Nigeria, Democratic Republic of Congo, Ethiopia, Somalia, they have been lagged behind in achieving the maternal child health delivery targets and outcomes, especially the under 5 mortality, neonatal mortality, as well as the maternal mortality. So because of that, we are looking to focus these developing countries and what are the issues and what are the problems and challenges they face in establishing a proper health system within their countries, as well as in promoting the health service delivery within these countries, and how they came up with those challenges and what several interventions they developed to improve the health system in their country, as well as improve the service delivery in their country. So that's why today we are going to discuss the health system, what is actually a health system, and what are the components and what are the main key components of the health system, what should be according to WHO framework. And then we continue to discuss on health service delivery. What are the different, case studies, which countries have achieved what and using different interventions. So let's start with that. My name is Dr. Mohammad Bilal Siddiqui. Okay, let me share the screen and I hope you can see my screen. Hasna, if you can tell me if you are able to see my screen.
Yes, I can see it clearly.
Thank you. Thank you. You can contact me at my email address here, bilal@thequantumnetwork.com. The Quantum Network is an online publishing agency which work on open access platform by providing the scholarly books on STEM research like science, technology, and mathematics and all other domains. And it also have a platform where you can, they have several research journals as well. The first of its kind is Journal of Women and Child Health. So I am the founder CEO of this House of Quantum Network. Now, the topic is health systems and health service delivery in developing countries, and what should be the best practices to achieve the better health system and achieve the better health service delivery in developing countries. Now, let's start with introduction. In the introduction, we will discuss the structure of health system in developing countries. But initially, we will see what are the components. Introduction. Okay, in the introduction, we will find out what should be the definition from the WHO and from different sources of a health system. What should be the health system and what actually a health system? So basically, health system involves all those organizations, whether these are NGOs, whether these are private agencies, whether these are government agencies, whether they are research organizations, whether they are schools, whether they are universities, academia, whatever. All those organizations and institutions, as well as the resources. And when we talk about resources, resources means research publications, research journals, um, uh, periodicals, reports from WHO and other agencies which which are very credible, and all those people whose primary purpose is to improve the health of the community. So basically, a health system include all the organizations, institutions, resources, and the people whose primary purpose is to improve the health. And what should be the main crux, main component of the health system is that health system includes everything, every activity, every involvement that promotes, like promotion, prevention, restores, like providing the secondary and tertiary care, and maintain the health, restores and maintain the health system. By maintaining, we say providing the tertiary care or rehabilitation to the patient. Just like we might have read primary, secondary, and tertiary healthcare system in developing countries. So the primary involves promotion, prevention. Secondary involves restoration by providing the secondary and tertiary services through the hospitals and tertiary healthcare centers, and maintaining the health. This is what WHO has suggested. All right. So what should be the key component? When we talk about the key component of any health system, it should include, WHO suggested a building block framework. This is a very well known and very well known and very well promoted framework, which says that any health system should contain minimum of these 6 domains. Number one, the system should be able to deliver the services, healthcare services, through effective, safe, and quality personal and non-personal health interventions on the basis of equity, not equality, equity, according to the need of the population. The health system should contain the health workforce, like human resource, all the doctors, nurses, paramedical staff, polio vaccinators, and community health workers, lady health workers, and all those teams which are like ambulance drivers, and every other domain, you name it, and these are the people which are included in health workforce. These should be trained. They should be able to provide the services on the basis of equity in timely manner. And when we say timely manner, time is very critical and crucial, because when we provide the services on time at the time of need, the service is very important. However, if we don't provide the services on time, obviously there is no need to provide services beyond the time has passed. Now, health information system. Health information system is a system in which we gather the data, we collect it, we accumulate, and we clean the data. It's all electronic and manual, including every aspect of data collection. And then we analyze the data. It carries the dashboard. It has all the emergency responses, and in which area of the city and which area of the country we have high burden of polio, we have high burden of all these infectious diseases, high prevalence of child mortality, and all these things. So the health information system is a sort of dashboard, but however, it contains the dashboard. It's actually a broader terminology in which we collect data, analyze, clean it, analyze it, and then we analyze and make the reports through the health information system. The health system should contain the medical products like vaccine and technologies. Medical products, it include when we provide the tertiary care to the rehabilitation and tertiary care to the population which needs the tertiary care. For example, any diabetic patient, any hypertensive patient. So there should be availability of cardiac stent, for example. There should be availability of artificial limbs, prosthetics, and vaccines, all the vaccines which are included in routine immunization as well as in um, exaggerated immunization. Like in Pakistan, we have high incidence of polio. So here we carries out a routine immunization on a routine basis. But on the monthly basis, after 3 months, after every 3 months, we provide extra coverage to the polio cases and increase the coverage of vaccination by running the campaign after every 3 months. So all these things like medical products, vaccines, and technologies. Now, when we talk about technologies, technology in the current time, for example, in the current period of artificial intelligence, the world has been changed enormously. Initially, we were just gathering the data and running the analysis and then carrying a dashboard. However, currently nowadays, all the predictive model analysis, all the predictions, and based on that, the data holds a very big importance. So based on that importance of the data, the technology is standing. We are currently facing a huge demand from the medical field that the data should we should work on data by using the big data and then incorporating in different artificial intelligence models and algorithms and different areas so that we can predict the occurrence of major infectious disease epidemic, pandemic, as well as current estimates and prevalence, which areas to focus based on data. All these things should be the part of technology. Health financing is all very important. It helps us in allocating the proper finances, proper money, proper money to those areas, to those area of interest. For example, if a country has a high incidence of maternal mortality and child mortality, but it does not carries huge burden of smallpox, for example. So all the finances majority should be focused on maternal child health and child mortality. So financing plays a very important role based on the need, equity, and leadership and governance. Governance hold a very important role as well. So all these, for example, governance. What do we mean by governance? If anybody has any idea, I can explain it. Leadership and governance means that the government and the health system should be able to minimize all those challenges which any health system and which their own health system are facing through the policy and through the advocacy. All these things, when applied to a health system, it helps us in improving the health system and providing the better services and quality services on a timely basis to the needy based on equity. So these 6 components falls under WHO building block framework. And this is very well known. You should keep in mind whenever you anyone asks you what do you mean by WHO building block framework, it means that any health system should contain all these 6 domains in itself. Okay. Now these are the key component. Why do we study the health system, and why do are we focusing on developing countries especially? Initially, I have told you about the importance of and why we are focusing on developing countries, because majority of the developing countries, especially the South Asian countries and sub-Saharan African countries, including Nigeria, Democratic Republic of Congo, Ethiopia, Nairobi, all these countries. And in South Asia, we have Pakistan, China, and India. India, why India? India has improved huge amount of indicators, and it has worked on improving the indicators. However, since India is a huge population, a huge country, there is a disparity of availability of services in India. For example, a country which is very huge, major portion, even a smaller portion of its population not receiving any better health service, that amount of population will be obviously larger than a country which carries a less amount of numbers. I hope I made it clear to you. So basically, when a country is larger, so the population, even a smaller population of that country, carries a huge burden. So these are the countries which are developing countries. So why do we study the health system? To improve the health outcomes. Um, when we study the health system and health service delivery means all those efforts, all those systems, all those interventions which we adopt to deliver the healthcare services. And healthcare provider is a person who provides the service to the recipient includes the population. Whether it is doctor, whether it is nurse, whether it is paramedic, whether it is polio worker, community health worker, CHWs, community health worker, LHWs, lady health worker, all these people, even a person who is a stitching man in the emergency department, he is a service provider itself. So health service delivery, when we study any health service delivery, what we are focusing, we are seeing that if our country, whether our country is providing a better health service, and whether based on that health service delivery, what are the outcomes of those efforts we are working on. For example, in a country where child mortality rate is high, so we want to obviously learn and focus what are the current practices of health service delivery in our country to deliver the services to the children. And are we providing a better services? Are we providing the timely services? Are we providing the quality services to the children of need, who are in need? And what are the outcomes of those efforts? Like, what are the outcomes? Indicators. Health outcomes include all those indicators. For example, under 5 mortality, for example, neonatal mortality, for example, child survival rate, for example, number of child deaths in particular area, maternal mortality. These are health indicators which shows the outcome of our efforts. Economic impact, we need to learn the economic impact of any country, since the human beings who are living in any country, if they are receiving the better health services, obviously they will be a better human being and individual later in life. The quality of life they are receiving through the health service delivery, if they are receiving the better health service delivery, obviously they will be able to provide better services in future. They will be a better part of the community, and they can provide a better services to the community, whether they are teacher, whether they are TV representative, host, or whatever. Equity and access, importance of health. If a country is able to deliver the services, health services, through their health system on the basis of equity and access. What do we mean by equity? Equity and equality are two different terms. Equality means that you provide same services to everyone, but on the basis of equity, you provide the services which are to those only people who are in need, right? There is a picture in the Google, if you search it, equity and equality, you will see 3 children standing to watch the football match in the ground. They are standing at the corner. And then if you provide this, one child is smaller in height, the other one is little bit longer, and the other one is more longer. So if you provide the boxes to them, or any stairs, so that they can stand and watch the game properly, if you provide them similar sort of boxes, similar height and similar weight of boxes, it means that you are providing the equal services to everyone. But the smaller child needs more larger and more bigger and more taller box so that he can reach and see the match easily. So that is his need. So we should provide a bigger box and taller box to that small child so that he can watch the game and watch the football team. So equity and access should be there. For example, when we talk about the coverage of our vaccination in throughout the country, that is one of the most important part of infectious diseases these days. Um, when whenever we talk about what should be the coverage and how much, for example, let's suppose I can put it this way, that the efficiency and effectiveness of our interventions, our work, and our efforts based on the coverage we have achieved in providing the vaccines. In a country where the coverage is high, we can say that our health service team is providing a better health service delivery through the vaccination. If a large number of people are receiving large number of vaccines on timely basis, it means that our health service delivery is working better. All right. Sustainable development. When we talk about sustainability, in Millennium Development Goal, which ended in 2015, um, um, we found several, challenges and several mistakes what we made during the period of 2015. Those mistakes later on were put together and provided a better framework, which is called Sustainable Development Goal after the 2015 era, right? And then another target was given, which is named as Sustainable Development Goal. Some of these targets are ranging from maternal child health, environment, poverty, and other domains of human life. So they have to achieve by 2030. So all those efforts which made during the Millennium Development Goal era before 2015 were some of them our mistakes we have done, different countries have done. So to overcome those mistakes, Sustainable Development Goal came into existence, which says that all your efforts should be sustainable. For example, the big companies and big agencies like WHO and all other organizations, when they give money, seed money to the developing countries, so that they can work upon their improving their health service delivery and health system. And it has been seen that when that seed money finishes, the all the efforts become zero because the program get stopped. So the government agencies, the international agencies, they asked all those developing countries that we will give you some seed money. However, you should provide a better, out of box ideas and new policies and new proposals to work on different domains of women and child health, nutrition, environment, keeping in mind the sustainability. All your efforts should be sustainable so that when the money is withdrawn, the project itself keep on going without the need of extra money. We can provide you only limited amount of money. So that is sustainability, which is one of the important part of the health system, which should be the important part of health system and health service delivery. Resilience. Now, what do we mean by resilience? Resilience means that the community, the population into which we are providing the services, they should be able to accept our interventions and all our services. They should not be, against the services which we are providing. For example, let's take example of polio in Pakistan. You all people might have heard that in Pakistan, the polio is Pakistan is unable to, eradicate the polio disease throughout the country since 2015. There are so many myths and so many concept people are thinking that probably the data has been forged or things like that. But actually, the main issue is that the people of population, the residing population, the people who are living in country, they are against the polio vaccine and they don't want to, take the vaccine from the government because what they think that if the polio vaccine we will take in our body, obviously it will make us sterile and our future children will be sterile as well, and they will lose their power of reproduction slowly and gradually over the period of time, just like what we thought about the COVID vaccine, that after 2 years people will start dying after taking the COVID vaccines. So these are some of the myths. Basically, that's a long story. So resilience should be the part that community should accept all the efforts and all the services provided by the government rather than, rejecting it. Relevant statistics, all those statistics which are available and which are relevant for that particular country. For example, a country which have higher prevalence of under 5 mortality and neonatal mortality. I hope you all be understanding about the neonatal and under 5 mortality because you are masters of health policy and administration students. So under 5 mortality, and these are the indicators to assess the under 5 children mortality and neonatal mortality. Neonates are the children who are under 28 years of age. So where were I? Relevant statistics. If a country has high number of child mortality and their rates of under 5 mortality and rate of neonatal mortality are high, then for that country, what are the major statistics which are relevant? Obviously, under 5 mortality rate, obviously neonatal mortality rate, obviously maternal mortality rate. So these are the relevant statistics which a country should focus in their health system and health service delivery so that they can provide a better services. They can assess their performance over the period of time, that whether are they going in a better direction or they should keep on higher pace. So this is the importance of health system, that all these domains, health system should be able to provide the services and the assistance to the government and the population. All right. Now let's about different models. We have different models, basically 4 type of models in health system proposed by different researchers, different policymakers, and different um, uh, social scientists and these populations. So the first is these models help us to provide the better health system and service delivery to the population. The first one is Beveridge model. Beveridge was actually a British economist and social reformer, and he is the one who created National Health Services in England in the year of 1948. So Beveridge, basically in 1948, he proposed a model which says that none of the government, none of the population residing, like no population should should give the money to get the services from the government, health services. He said that it is the duty of the government that the government should provide all the services to the population, to the residents, to the citizens, and citizens should never should be responsible for their medical bills or all the expenses. Government, the countries which are focusing on such model, Beveridge model, are United Kingdom, New Zealand, Spain, and Cuba. These countries, they provide through their health system. In England, we have National Health Services. In Pakistan, we have Pakistan Health Services. In India, they have Indian Health Services. So different countries have their own different health services, and that health services should be, through the budgets, through the country budget and all those parallel modeling system, they should be able to provide the free services to the population rather than the population should pay for it, right? So that is one of the model which is called beverage model. These are the countries which provide the services. However, what are the strengths and limitations of this beverage model? Since the population has nothing to has is not allowed to pay, and it's actually the government responsibility. So universal coverage, like the services are provided universally throughout the country, because the government is responsible and government is sitting up on the top, and they are providing at a top to bottom level. There is a model which is called top to bottom level. So and there is another model which is called bottom up approach. So the top to bottom approach, in which the government is providing the services to the population, usually it is universal coverage of services, equitable access based on the need. The government usually provide, if those countries which have beverage model, which are focusing on beverage model, they provide the equitable access of services to the population, right? And cost control as well, because government has to pay everything for every person. They provide the cheap and less costly services to the population. However, there are major challenges for such countries and population and people living in those countries. What are those challenges? Obviously, the government, for example, a doctor is sitting, a gynecologist who is sitting in a clinic, in a private or government clinic, and she has a huge workload, because she's looking after a large number of population and citizens for the services to provide. So there will be long waiting times, obviously potential for lower efficiency due to government control, because government is focusing on providing the money. So obviously time is always important. Most of the time we have seen that people are not getting timely services for their diseases, or because of non-availability of services, non-availability of X-ray machines. If a X-ray machine is broken or damaged, they will not receive it on proper time, and then people will suffer. So these are the challenges which beverage model faces, and those countries which follow the beverage model. Now we have another model which is called Bismarck model. Bismarck is a politician, and he's the author of many books written for the health service delivery and health system. And he's a diplomat as well, and he is by profession farmer. So in 1883, long time before the previous model, he proposed that the concept of social insurance, that the person, for example, in America, in United States, we have seen that people have to pay large amount of money for their insurance to get the services on a timely basis. So this is a concept by Bismarck. Countries like Germany, France, United States, Japan, and Switzerland, they follow the Bismarck model, in which they say that social insurance model is a healthcare financing system where contributions from employers and employees fund universal health coverage for all citizens, ensuring access to medical services. I hope you're understanding that social insurance is a pool of money in which all the people, all the residents, and all the employees and employers, they put their small contribution, and whenever any person gets sick or ill or need any services, health services, he will be paid from that particular pool. So that is the concept of social insurance, right? And it is named after a politician called Otto von Bismarck, and it was proposed in 1883. The major strength is universal coverage, obviously, because the government is looking after for that. Competition among insurers, yes, that is the point. There are so many insurance companies who work on that concept, and they provide the services through having collaboration with hospitals and primary and secondary tertiary care hospitals, not specifically primary, but secondary and tertiary care hospitals. So will always be a competition among insurers. Why? Because if a person has, for example, type 2 diabetes, and his diabetes is mismanaged, and there is another person in another part of the city who has the same disease and same condition and same criteria, obviously they need services from the government. But obviously if a huge number of population is diabetic with same similar context, they will need obviously services from the government, and there will be a huge competition among the insurers. So there is a high quality care. However, strength is high quality care. They get the services on high based on high quality, because majority of the service providers are private health system, not the public health system. What are the challenges? High administrative cost, because it involves the insurance companies. They have to pay the premium, and if, for example, a person has to undergo a big operation, for example, cardiac bypass or orthopedic surgeries or major, surgeries, their premium get increases. So they have to pay extra amount of money to get to compensate that amount what they have taken from the government, from the insurance. Potential for inequality if some insurers offer better services. Obviously, there are some insurance companies, they provide different packages. If insurance company pay a better package, majority of the insurers will go to that particular company and get their services. So there will be a disparity of services among the different insurers. So obviously that is one of the challenge. All right. So how many models we have learned? Beveridge model and Bismarck model. There is another one which is named as National Health Insurance model, which is a combination of Beveridge and Bismarck model, which says that government funds are paid through taxation. Now, taxation and social insurance are different concepts, right? Social insurance is separately for the health insurance, right? However, taxation is amount of money what we pay as tax, and that tax has different bifurcations. For example, if I pay a tax of $200, the $200 will go, some part of it will go to the health, some part will go to the defense, some part will go to education, and so on. So I have to pay only $200, but out of those $200, some money will go to different domain, and this is how the taxation will tax services will utilize our money, the money from people, to provide the services, whether it is defense, whether it is education, whether it is health services or whatever. So it is a combination. NHI insurance model is a combination of Beveridge model as well as Bismarck model, right? The countries which provide such model, which work on such model, are Canada, Taiwan, and South Korea, as well as Uganda. Okay, universal coverage and administrative efficiency and choice of providers. These are some of the strength. However, long waiting time, because obviously it involves the taxation and insurance as well, because it's a combination of insurance and taxation. So long waiting time will be there. High taxation required for funding. Government should be able to provide some amount of extra money as a subsidy to compensate the amount what they are needed, what the population are needed. So that's why high taxation is required for funding. All right. There is another last model which is called out of pocket, right? Out of pocket model. Out of pocket means that in country like Pakistan, in country like Somalia, in country like India, India is now moving forward with health insurance system, the Beveridge model. However, currently major part of India and overall in Pakistan, we have out-of-pocket expenses. There is no insurance system. There is no employee system. However, in certain part of country in Pakistan, there is a mixture. There are insurance companies in which you provide the services. For example, I am working in in one of the uh, um, factory, and the factory owners asked me to pay some amount of money out of my salary, and that amount goes to the insurance companies. So in Pakistan, there is a mixture of beverage and Bismarck and out-of-pocket expenses. If I have to go, if I don't have any insurance, I can take insurance. I cannot take insurance as well based on my needs and my priorities. So in that case, if I don't have any insurance, policy, I can opt for out-of-pocket expenses in Pakistan, in which I provide for the services what I am getting, right? So all the services out of pocket, you have to buy the medicines, you have to buy. So these there are so many, challenges with that out of pocket expenses. For example, if doctors suggest me that a medicine which is high and very expensive, then I cannot afford that particular high cost medicine. What should I do? So in that case, I have to buy because doctor has written me in the prescription that particular medicine. So in that case, I might, take loan from somebody for my medicines. In Pakistan, the medicines are getting so costly these days. So based on that, a huge number of people suffer financial disabilities and financial problems to get over with the issue of buying the medicines suggested by the doctors. So many developing countries such as India, Pakistan, they have out of pocket model. Strength direct access to the services for those who can afford. Through the out of pocket model, we can have direct access to the doctors. We just pay the money and get the specialist booking straight away, and then we can get his services. If I have, if I am, a highly, if I'm, if I'm having good amount of money in my bank, obviously, then I can pay for a best doctor, best hospital to get the services. But if I am not able to, not having good salary, or I don't have any good amount of money in my bank, obviously I cannot afford the best services. Then I have to go for the government hospitals which provide free of cost services. And in that case, I have to face long waiting hours and administrative delays and things like that. So these are the strength and challenges of out of pocket model. So giving the overall overview of the health system model, we have four different models of the health system. We have different models for the health service delivery as well. So this is four models for health system, which include beverage model, Bismarck model, NHI model, and out of pocket model. Right. Now, moving on. 1 minute. Moving on, structure. Sorry. Challenges. 1 minute. Structure. Okay. Structure of health system in developing countries. Majority of the developing countries like India, Nigeria, Pakistan, Bangladesh, Somalia, Ethiopia, all these countries which are developing countries, what structure usually they hold in their health system? The WHO suggested that there should be 6 domains in any country's health system, which include service delivery, health workforce, health information system, which I have already told you, medical products, vaccines and technologies, health financing should be there, leadership and governments. However, majority of the countries have a mixed method. Their health service delivery are compromised. Their health workforce, uh, for example, if in Somalia, for example, in Democratic Republic of Congo, in Congo, there is one doctor for 10,000 population. 10,000 of people. So how can one doctor can provide services to 10,000 of population? It should be like as minimum as possible to provide better services on timely basis, right? So health workforce should be um, uh, proportionately relevant to the population, right? Health information system. Now, countries like developing countries, majority of them, their health system, health information system is highly compromised. They don't have data. They have segregated data. Segregated means that they are getting data from one part of the country and they are not getting data from other part of the countries. The data is not timely and exactly according to the time. They have the reports 2 years back. So what is the point of having a data 2 years old to implement a policy right now, right? So the data should be timely and should be relevant and should be reliable as well, right? For example, in a vital registration system, like probably you might have heard about vital registration system, civil registration vital system. In civil registration, like how many people have died, how many people are married, how many people are currently alive, how many are married, how many are widowed. So these are the civil registration system data statistics which a country usually holds, right? To provide a better health services, to provide the better resource allocation for plannings. So majority of the countries, majority of the developing countries, when I'm talking about this, developing countries, they lack a proper civil registration vital statistics system, CRVS. They don't have timely data on how many people they have currently in country. They don't have proper data and timely data on what is the current death toll in the country, what is the current death toll of children, what is the maternal mortality rate, how many people are married. So since they don't have any data, so it means that they cannot properly allocate resources based on the need. So that is one of the major issues, these developing countries, that their health information system is very weak, right? And because of that, they don't have data. They cannot, develop any specific interventions to improve the survival of the population. So all these things, all these components are suggested by WHO, right? As a building block framework, should be the part of component of, should be the component of health system. Now, based on that, uh, what are the role of non-governmental organization and governmental organization, INGOs and local NGOs, non-governmental organization? Well, when we talk about NGOs, we talk about what services they provide. They provide service provision. For example, NGO like there are so many NGOs in different countries which are local NGOs as well as international NGOs. When we talk about international NGOs, for example, WHO, for example, Save the Children, for example, Oxfam, for example, many more. So they provide, when they provide the services, it means that they provide the consultation through the doctor by involving the government. They provide the services through vaccines. They provide the services through ambulances and different domains. So they are involved in providing services to the population. Currently in Pakistan, there is a new concept of what we call human milk bank, in which those mothers who cannot feed their children and they are not getting milk during their pregnancy, after their pregnancy, they can take the milk from the milk bank. Other mothers have donated their milk, breast milk, so that they can, the mothers who cannot afford or who cannot afford in terms of they cannot provide the milk, they can get the milk from the government agency, Human Milk Bank. So these and this program is being supported by UNICEF. UNICEF is an international NGO, international agency under the UN, United Nations. So basically, these are all agencies, institutes, and all NGOs which provide the services to the community. They provide advocacy to the community. When we talk about advocacy means that to advocate certain issue. For example, child mortality is one of the major issue in Pakistan, India, Nigeria. So there are so many advocates who talk about this particular issue in the country to the population, that this is one of the major issue. People, please think about it, and this is one of the major issues, so that you should boil the water and get all the food properly done and properly cooked, so that your child doesn't get sick and doesn't get die. So these are the things which the advocates provide through their advocacy. Capacity building. There should be these NGOs, they provide the capacity building to the human resources within those countries. Like, for example, doctors are not very much trained. They are trained in their own trainings, in their own clinical trainings, but they are not very good in counseling. They are not very good in proper timing, providing proper timing to the patients, right? So they are not very much trained in dealing the emergency cases, when to break the bad news that your patient has been died. That is one of the major issue in emergency department, that what the emergency doctors face, that breaking the bad news, right? So they should be very good communicator if they are working in emergency department, to deliver a bad news to the population. Because if you say illogical words, and you choose improper words while delivering this news to the close family members, obviously it will ignite, and it will increase the violence. They will be angry, they will be ambush, and they will start hitting the patient doctors. So that there are so many cases I've seen in which doctors are beaten, doctors are face violence, physical, verbal, mental, whatever. And now currently I have been working in since 2015 on a project in which violence against doctors. And then we run the multi mixed method study, and so many, we involve the ambulance services, we involve polio workers, that what are the issues what you faced during the violence dealing the patients. So they told us so many important information, and based on that we develop policy paper, that there should be a a rule in the government, an act, a bill should be there in government, that if a doctor should be beaten, the person should get the charge for through the police and through the law department. So after a thorough efforts, we have been able to approve a bill on that. And currently there is a bill and there is an act in the law, that if a doctor is beaten, you will be have to pay that amount of fine or imprisonment, or both, or whatever. So this is all I have been passed through, and I've been involved in providing and creating that bill. So capacity building of the doctors, how to break the bad news, how to communicate, how to counsel, right? Research and innovation. The NGOs should be currently NGOs are majorly involved in research and innovation, and they are based on that they provide money to the researchers internationally and nationally as well, and they ask for new interventions, out of box ideas, sustainable ideas, and whichever who provide the best idea, they will get the funding, and based on sustainability. And then currently, since we are working, we are in a age of artificial intelligence, so our ideas, new out of box ideas, should incorporate the artificial intelligence as well. So there is a huge competition in research these days, how to get the new ideas to improve the health of the community, right? Examples like Medicine Sans Frontiers, Doctors Without Border, they provide emergency medical care in crisis situation. Local NGOs in every country, they provide community health education, primary health care, advocacy, and things like that. What are the impact of overall non-governmental organization is that accessibility, enhancing the access. they provide the accessibility of services through their services, right? Like their services should be accessible to the larger population, and this is what their outcome should be. The quality of services, the services should be of quality and should be sustainable. All the efforts should be done in a sustainable manner, so that if a seed money is removed or finished, obviously the whole project should not be stopped. It should keep on going. All right. So these are the structure of health system. These are the major components of health system in developing countries. Now, in developing countries, there is a concept of public and private health system. You must have learned about it and you must have known about it, that what is the difference between public and private hospitals. Public is the public owned hospitals, whether they are primary healthcare, secondary or tertiary healthcare. These are public hospitals and they provide services free of cost most of the time. However, in some countries like some countries, they provide some additional cost for the blood tests. Some countries they ask for medicines because they don't have good amount of money through the taxation, and their taxation system is hugely compromised. So some of the countries they ask for some of the contribution from the out of pocket expenses, in the form of out of pocket expenses from the community, right? So public hospitals are public ownership, falls under public ownership, and private hospitals are privately funded and operated, often through out-of-pocket payments or private insurance. What are the strength for the private hospital? Greater efficiency, obviously, because they are getting money. They are taking money from the population, from the patients. So they are providing the better efficiency and provide better services. And they have huge amount of innovations, and quality of care is also increased. What are the challenges? Inequities in access. What do we mean by inequities? Inequities means that if a person has huge amount of money, if I am a rich person, I can go and take a immediate booking with the doctor, whether I am sick or little bit sick or slightly sick. But if a person who have borrowed the amount of money, who is not very much rich, but a little bit not rich, so he took the money from somewhere as a loan, and then he took the amount, and he will be provided less priority as compared to the rich person. So these are some biases in the private house system which compromise the equity concept of equity in access. Higher cost, obviously, because they are getting a huge amount of money and there is a huge competition among private hospitals, and sometimes focus on public health goals. They don't focus on public health goals because they are earning machines, right? These hospitals are earning machines, majority of them, and they focus on finances only. They are not very much into that whether the sustainable development goal have been achieved, what are their child mortality rate in that particular hospital, things like that. Even most of the hospitals, some of the hospitals, they don't even disclose their data because they don't want to show that how many mortalities have been done, have been undertaken in their hospitals. In that case, their hospital will be seen as a hospital with less services, right? So these are the major issues and challenges in private hospitals. Now, in public hospitals, these are obviously government funded and operated, providing free or subsidized healthcare services. The strength is equitable access to essential services. Like because government is providing the services, then it means that government is providing all the services to whole population, and it is equity based, right? Comprehensive coverage of preventive and primary health care. They provide the comprehensive services to the community through prevention, on the basis of prevention and secondary treatment. Challenges, what are the challenges? Since government is providing the amount of services to the population, to the patient, there will be limited resources. If there is a element of corruption in the government, obviously the money is given to the services is provided to the less needy people, based on, contacts and connections between the people, rather than on the basis of equity. Bureaucratic inefficiencies. There are cases in which people, they mismanage the amount of finances to the hospital given by the government, and take that amount of money in their own pockets, right? So these are some corruptions cases. Sometimes lower quality of care as well, because doctors are not getting enough amount of money, salaries, so they provide less priority to the patients, and they are seen out sitting outside in cafeteria rather than watching the checking the patients, right? So there are cases and there are cases and there are cases which have been seen in developing countries in which people have suffered huge amount in public hospitals, right? So that is the structure of health system in developing countries. Now, when we move, what are the challenges? When we talk about challenges, infrastructure and resource constraint, we have human resource for health, right? In having a best health system, we face challenges in terms of infrastructure like hospitals, right? The public hospitals, they don't have huge amount of money to develop new building, to create a new building for, for radiotherapy, for cancer therapy, because they don't have amount of money. And in that case, the people are suffered, right? Human resources for health. Uh, there are cases in countries, like what I've seen, that the doctors, they don't want to go in rural areas to provide services to the rural community. Rather than they prefer to sit in metropolitan city and mega cities, so that they can earn better in big cities rather than going to the suburb areas and the old countrysides. That is one of the reason that there is a huge number of doctors in the cities, in the big cities, but the doctors are not available in the rural areas. So that is why the rural population, they face challenges in accessing the health services. And that case, they have to travel all the way from countryside to the major cities, and then get them self-treated. Currently, new ideas and new concepts have been evolved in which telemedicine or ham health, medical health, mobile health, they have been introduced, in which the rural population can have better services through the best specialist in town while sitting in their home in rural areas, and paying the same amount of money, the the amount they have to pay while physically being available in the clinics in big cities, right? So human resources is one of the major challenges as well in health system and health service in providing a best health service delivery. Financial barriers, right? In financial barriers, we have how high out of pocket expenses. While many individuals in developing countries face how high out of pocket costs for healthcare services, leading to financial hardship, obviously. The majority of population, they face high pocket, like in Pakistan, for example. In India, if I don't have any insurance, I'm illiterate person, and if I am unable to have a better job, then my employer will not be able, I will not have any employer with me. So I cannot get the insurance plan for my health services. So in that case, I have to pay from my own pocket whenever I get sick, right? So this is high out of pocket expenses. That is one of the financial barriers in accessing the health services. Limited health insurance coverage as well. I've told you that since people are those people who live in slums areas and rural areas, they can't have a better health insurance coverage, right? Access to care. Access to care means services. Those people who are living far flung areas, in geographical areas, they are in rural areas and remote areas, they are unable to receive the best services available in the cities. So they have to travel long distances to the cities to get the people, to get the services from the best hospitals. Transportation issues as well. So these are the issues, geographical barriers, socio-economical barriers as well. Those people who don't have good amount of money, and they cannot earn good amount of services, they are socially left behind people. So they cannot access the best services, healthcare services, to get treated. So these are financial constraint, education and awareness as well. Those people are not educated, those people who are not working in industries, they will have to face hardships. Okay. Now, another challenge is health information system. What I've told you, that health information system involves data collection and proper dashboards and proper, analysis of the report and use of information technology. Developing countries, they face huge, challenges in terms of having a best data collection program or method, and management issues, as well as they have incomplete data, they have fragmented civil registration vital statistics systems. Because of that, they have no timely and quality and better data and reliable data. Only they will be facing unreliable and not timely data. Because of that, they cannot make the health policy and planning based on current estimates, what the current estimates and prevalences of different diseases, what are the huge burden of diseases currently the country is facing. So they don't have any data, so it means that they cannot make policies and they cannot develop timely interventions to improve the health conditions. They don't have, since they have no data collection method, their information system is weak, so obviously they are lacking in health information technology as well, the use of information technology in the health. So all these things, when put together, the countries are facing huge challenges. Wherever you go, in which domain in health you go, you face challenges. And obviously, who is the main sufferer? Obviously, the population, the people, the patients, the residents of that country. So these are the major challenges in developing countries. Governance and policies, right? In governance and policies, corruption is major issue. In developing countries, especially since there is a huge competition to earn money among the people, among the population, everyone is beyond the ethics. Everyone is just, earning money and trying unethical ways to earn money and fill their pockets. So wherever you go, you will find corruption. You will find corruption in dealing patients, attendant, the person who is standing outside the doctor's room, who make the line of the patients and who ask patients to take their turn and come in the room for doctors to show. So that person even take the money from the patient to show them on a priority basis. So these are the, at this point of time, there is corruption. And if you go further high up in ministries and everywhere, you will find huge amount of corruption and huge amount of illegitimate practices. And who are the sufferer? Obviously, the population is sufferer. Bribery is there, and whatever name you take, whatever fraud you take, you will find it. Weak policy implications. In You might have seen, I actually see it every day. You might have seen, I'm not sure that who has been seen these issues or not, but I see it every day that the person who is health minister has nothing to do with health. In actually, he does not have any experience of health. He is a finance person and he has been provided with health ministry. Now he's a health minister. So how come the health minister take a better policy making, and how he can, develop new policies, and how he can head the whole health system in the country? So that is one of the weak policy implications, right? So now another one is cultural and social determinants, right? In Pakistan, I'm talking about Pakistan now, right now. In Pakistan, we have huge amount of polio vaccines every day, polio cases. Every day we see a new case coming out in our statistics. So why is it so? People are giving resilience. People are not, taking these vaccines from the government, and they are not giving hardship to the health workforce that we are not going to take this vaccine and we are not going to, get protected our child. Why? Because they have myths, they have misconceptions, they have misunderstandings. And where these misunderstandings came out, so many people who have vested interest in these issues, they just give a little bit idea to the population and misinform them and create a misunderstanding, and then here you go. So these are the things which have been seen, and these are the cultural and social determinants. Gender inequities, obviously in gender inequities, um, females are giving less priority. Even the females, they do not take interest in getting the services properly on timely basis, right? Mothers, they are engaged in providing household duties. They prefer not to go to the hospital because their household activities are get compromised. So they say that I will take some medicine and I will take Adol and something like that, and then I'll be fine. So then slowly and gradually their diseases become complicated and they face challenges and things like that. So these are gender equalities, inequalities and inequities as well. So these are major challenges in developing countries uh, in having a better health system. Governance and policy. 1 minute. Now, what are the health service delivery models in developing countries? There is a primary healthcare approach, there is secondary healthcare approach, there is tertiary healthcare approach, then there is community-based healthcare approach, there is mobile health clinic concept, there is telemedicine and e-health concept as well, there is integrated health service delivery as well, and there is public-private partnership concept, right? Primary healthcare center. Primary healthcare approach is providing the universal coverage. The primary healthcare approach as defined by WHO emphasizes universal access to essential health services, community participation, and intersectoral collaboration, right? So through primary healthcare center, which are the small centers located in every corner of the city, they provide the primary healthcare services to the needy people. Um, um, they provide the universal coverage, they provide the proper community participation. They are the part and parcel of the community. So the community engages with the doctors who sit in that primary healthcare. There is an intersectoral collaboration as well, because the international NGOs, they pay good amount of money for establishing a large amount of primary healthcare centers scattered throughout the country, right? What are the advantages? Accessibility. They provide the accessible services. They provide the cost-effective services because these are mostly owned by public government. What are the examples? Cuba's primary healthcare system. Cuba primary healthcare system initiated in long time ago, and now it has been involving community health workers and lady health worker as well, which travels all the way to every household allocated to them, and they provide primary health care, basic knowledge and understanding, and how to use condoms and how to use how to boil a water, how to make an ORS at home, things like that, just basic information. Similarly, Rwanda health system, they also have the same similar to Cuba health system as well, right? Community-based healthcare system. In community-based healthcare system, they provide the services are provided by the government to provide the knowledge and awareness to the community through local health workers, what we call community health workers, and outreach programs. There are so many outreach programs. For example, maternal child health outreach program, in which maternal health workforce and all those lady health workers and gynecologists, they provide outreach program through in a local community. So there are so many communities. If let's suppose there are 1,500 communities in a city, so in that 1,500 communities, the workforce has been divided, and they provide weekly and monthly clinics, and they provide services free of cost to from the government to the population, and they provide services, they provide knowledge, they provide information, everything, right? And because of that, the advantage is that the people, the doctors who are working in continuously in that community, they have relevant, and they become part and parcel of that community, and community is starting to acknowledging them, listening to them, and they obeying to them. Based on that, there is a increased access of services. People will trust on these doctors, and they get some good amount of knowledge and everything. Examples: Ethiopia health system and India's accredited social ASHA program, right? So here right now, community based. Now there is a new concept, two new concept in developing countries, which are called mobile health clinics and telemedicine and e-health systems. In mobile health clinics, large amount of like cardiovascular hospitals, they provide accessible services by providing a big tank, a big mobile health ambulance, and it is standing in the city, in the center of the city, where people can come and join the doctor. Doctor is sitting inside the clinics, mobile health clinics, and they are getting the services free of cost. Similarly, telemedicine concept is also emerging in developing countries, in which those people who cannot afford to travel all the way from far areas to the city, they can get access to the telemedicine. Integrated health services and public-private partnership, these are new concept. These are not, in fact, a new concept in which integrated health system, in which they provide the community integrated health service delivery involves coordinating care across various levels and types of health service to ensure comprehensive care, continuous care. All, for example, in typhoid, right? We know what are the causes of typhoid. Improper food, improperly cooked food, not boiled water, and unhygienic food, and dirty food, like flies sitting on the food and things like that. So, which sectors and domains are involved in this? There should be proper housing. So housing department and department of housing are involved to provide ventilated and properly ventilated houses, so that people does not get affected by typhoid. Similarly, water industry. Water industry is also collaborated with the government health system, so that they provide a better and filtered water. Similarly, those restaurants who provide the cooked food, so if their food is not properly cooked, the food inspector should be able to see and challan them and give them a fine. So all these industries, they are collaborating with the Ministry of Health to provide services for preventing the typhoid disease, right? So this is how the integrated health service delivery works, that all the relevant departments, they work in collaboration to provide services for improving the health condition, right? Okay. Public-private partnership is also another concept in which the government and the private agencies, they sit together on mutual basis, and they discuss what they can provide to improve the services. And then based on their expertise and based on their services, what they can afford, they sit together and they provide a plan to discuss how we can, work together. So this is what public-private partnership means. Okay, 1 minute. We have so many now, since it's almost 2 hours, Hasna. It's almost 2 hours. So I'm in a rush to finish it, because obviously the listeners will lose their attention over the time. And obviously I have to think about it as well. So I'll be quickly finishing all these 3 concepts and major domains. Case studies, right?
Okay.
Right. Case studies provide, why do we learn the case studies? Because different countries have adopted different new interventions and different techniques to improve their health system and improve their health service delivery. Right. For example, Rwanda's health system, for example, Brazil's health system, India's system, and Ethiopia's system. Rwanda health system transformation. They they introduce new concept. They introduce the community-based health insurance system. They introduce performance-based financing, that who will work best, they will get good amount of money. On that basis, they will keep on working. Decentralization is another issue in which, for example, government is unable to pay a huge amount of money to all the provinces altogether. So the government has said, I will give small amount of portions to the of budget to every province, and then every province should be able to run their own health system. Decentralization, right? So what outcomes they receive from the Rwanda health system? They receive the reduction in child mortality. Their in life expectancy has been increased, and their maternal health has been improved. Rwanda, right? Then we have Brazil's family health insurance system, in which they introduce the family health teams. Community health workers, they visit to the family and they provide basic information, basic services, family planning programs and things like that. And based on that, they integrate their own national health service, which is called Sistema Unico di SWOT, SUS framework, right? This is here, right? Okay, so this is how they integrate so many things all together to get the outcome, increase coverage of the family health services to the larger population over the period since it was improved into involved into introduced in 1994. So by 2017, nearly around 6 and 17, 21 years after, it's almost 60% coverage of the Brazilian population, right? Their health indicators were improved. They are providing the most equitable services to the community, right? Now coming to India National Health Mission, which is called ASHA, right? And it launched in 2015, and then later evolved into National Health Mission. They introduced accredited social health activist program, in which different activists, they came up, different health, different actors, media people, different contributors, the people who are well known in the community, they come and sit and they talk to the population about the health services through the advertisement and through TV programs and things like that. In the movies, they provide small caption as well, that smoking is injurious to health when someone is smoking. So these are the things like Janani Suraksha Yojana. There's a program which is based on safe motherhood intervention, in which they provide the institutional deliveries. There is another issue that developing countries, the children are born at home. And then when they are born at home using the traditional birth attendant, they are not getting the emergency services in case any child becomes sick suddenly. So then they have to go to the hospital, and sometime before reaching to hospital, the child dies. So because of that, when they die, the government does not have knowledge on how many deaths occurred within the home, right? So when we don't have knowledge on the number of deaths and number of reasons why those deaths have occurred, the government is unable to make plans and policies how these deaths can be prevented, right? So there are so many issues which are linked up with a proper health system, right? Okay. Now switching to Ethiopia health system, they, in extending to doctors, they provide community health workers and those people who provide services by visiting the household. They provide the establishment of health post in rural areas, where the doctors, the patients can come and take the information, and from there they have internet service availability. They can talk to the doctors in the cities as well. community participation as well. They involve the population, they involve the local people, they involve the religious leaders, and they involve them and they talk to them that they should focus on certain areas which are prevalent in the community. And then based on that, the community can listen to them, right? So these are, and based on that, there are so many outcomes and, improvements they received. Okay, so these are the case studies. What should be the best practices quickly? I'm sorry about that. The best practices for improving health system and delivery is strengthening the primary healthcare system. Primary healthcare system is the major building block of the services where the general people, they can go and walk in the small center and they get the services. We need to strengthen that system. We need to improve the number of doctors working in that health system. We need to enhance the health workforce capacity as well, increasing the number of doctors available in rural areas, for example, right? We need to improve the health financing, all those challenges which we focuses and we just learned. We need to, focus on those challenges. For example, improving the health financing mechanism, leveraging the health information system. We have to improve the health information system through different techniques, right? I'm not going to go into detail. I can provide my, notes and document of all the notes from this presentation to Hasna, and she can, if she want, she can provide it to the students as well. I have a detailed note as well, notes for this PowerPoint presentation, right? Enhancing the government and accountability, like reducing the culture of corruption and things like that, promoting equity and access to services, and utilizing technology and innovation in our all efforts. Okay. Okay, policy recommendations, last and least. Policy to support health system is strengthening. We should develop strong policies to support health system. We should involve internal and external international collaboration and aid from the international funding agencies to make our health system improve better and work on different domains. We should work on sustainable development goals and health indicators. We should focus on future research and innovation areas, particularly with the use of artificial intelligence and new arenas of information technology. And that's it. Thank you. Thank you.
Okay, thank you so much, Dr. Siddiqui, for your excellent lecture. I believe that we can deep dive on everything you told us. So this is the time to discussion and Q&A sessions for 30 minutes. For anyone who has questions, please use raise hand reaction, and I would pick you to unmute and tell your question. But for those who can unmuting their audio, please write down your question in the chat box.
Anyone who has question, they can simply raise their hand or simply unmute themselves and ask question. I'm totally available and can give answer for whatever you have queries.
Hi, Dr. Bilal. Can I
Hi,
have a
Noor.
question? Yeah. Thank you so much for your very insightful talk. Because I'm interested in the health financing area, so I'm just interested to know more about the Pakistan experience in their health financing aspect. Especially, you said that before, Pakistan has a kind of a mixed health financing system from out of pocket and other kind of approach. So how do Pakistan try to minimize out of pocket payment, as we know that if we rely on that kind of health financing approach, it will broaden the inequity in terms of health financing access. So how your country tries to minimize out-of-pocket proportion in order to minimize health inequity and achieving universal health coverage. And also with your example regarding the Cuba experience, as we know that Cuba is also one of the good example in trying to achieving efficiency in their healthcare, where life expectancy in Cuba is very high, but with the relatively low healthcare expenditure. What do you think the most important strategy or key success to achieve that kind of achievement in the Cuba experience? Yeah, thank you
Right,
so
thank you.
much.
Thank you very much, Noor Atika. Thank you very much for your query and very relevant questions. Thank you. Someone has put beautiful questions in front of me. Well, first of all, in Pakistan, the financing issues. Currently, we have a mixture of different models. Out of pocket, we have out of pocket expect model as well. We have insurance system as well. Where we have taxation system as well. Government, what we pay in the taxes, it goes into the pool and then we get the services. This is beyond the discussion that whether we get the services or not. We don't get it actually, but we pay the services. So that is the issue. So Pakistan is trying to get hold of so many particular challenges in terms of finances. Particularly, they are now following India because India is now at a verge of introducing health insurance system soon. By the end of hopefully 2025, they will be introducing health insurance. What I have learned and what I've gained from the knowledge. So Pakistan probably in 2-3 years later to India, they will introduce the health insurance system. And currently they are taking a huge amount of health insurance from in the form of taxation. Currently, Pakistan is taking 35% of someone's salary in the taxation. That is a huge amount of money, and that money goes into the expenses. Since the issue is, Noor Atika, there are so many things which are interconnected. In Pakistan, we have civil registration, vital statistics system very weak. We don't know on timely basis that how many people are married, how many people are died, how many people are living widowed and things like that. So how many children have been died during last 1 year. So since we don't know, we cannot allocate proper resources to those issues. We don't know what are the major issues currently, right? We know like 2 years ago what issues we had, but we don't know current issues, current priorities. So based on that, we cannot afford. So all these things are interconnected. Since number one, we have better data system, better health information system. Based on that, we can properly allocate proper finances. So all these things start with proper system of data collection and proper system of data assimilation. Once we have that, I always that's why I have been involved in creating maternal child health registry for the first time in Pakistan. So I'm getting people and enrolled all the doctors and different pediatric associations to get all the data from them so that we can create a centralized portal for data collection for child survival and maternal survival. So based on that, I always focus on having, first of all, the initial priority is having a database. And once we have the database, we can, properly allocate proper resources according to the need, and we can develop our interventions and things like that. Now, moving to Cuba, I hope I answered your first question.
Yes, thank you.
Right.
Yeah.
Okay. And the second is Cuba health system. Cuba health system, since they have least amount of money out of their taxes, out of the budget for the health system, yet they have achieved a better health indicators and outcomes. Why? Because they have focused on community health workers. They have focused on data collection methods. They introduced the health information system, their civil registration, vital statistics. They have integrated all those activities, all the departments and all the ministries together to work on different domains linked with the health system. So all these efforts, there are so many connections and integrations they worked on. So based on that, they achieved very quickly all these improvement over the time. So despite of having less amount of money in the budget, they still able to get hold of better outcomes.
So do you mean, in other words, that data-driven evidence is the most
Yes, data
influence
driven
factor?
and
Yeah.
based on current evidence-based medicine and data-driven medicine. These
Alright.
are the basic need and basic need and basic need of the current time.
Okay. Thank you. Thank you so
Thank you.
much, Dr. Bilal.
Thank you.
Thank you so much, Mrs. Nur Atika and Dr. Siddiqui. For anyone who wants to ask, feel free, guys, to ask a question to Dr. Bilal.
Mungkin bisa dalam bahasa Indonesia, nanti dibantu Hasna untuk menerjemahkan.
Yeah.
Since there is still no question, maybe just a little follow up from what Dr. Bilal respond to my question. Is that okay?
Yes, it's fine for me.
Okay.
I have provided my email address,
Yeah.
and I will provide to Hasna as well. So any queries or any issue, I'm more than welcome. I'll be happy.
All right. Just a short follow-up, Dr. Bilal, like what you said in responding to my question, that actually in Pakistan you have like tax-funded health financing as well, right?
Yes.
So yeah, I'm just wondering how many populations or proportion of your population which is already covered by that kind of health financing or insurance in relations to the universal health coverage aim.
Well, right now I cannot provide because I don't have any statistics of how much proportion is people getting out of pocket. But what I think is nearly about 43% of the population or 44% of the population is using the out of pocket expenses, and remaining other they are getting through taxation or insurance system. Insurance system is very those people who are the proportion of people who are getting through insurance, they are very least, like 10% or 15%, not more than that, because most of them, they are employed by the companies or employers, so they take the insurance from those companies.
Okay, so still there are many proportion of out of pocket, yeah, in Pakistan.
Yes.
All
And
right.
that is, very huge setback for the country, a country which has, a huge amount of corruption and financial instability. They have to focus on out of pocket. People are dying and they cannot afford the medicine. That is huge setback.
Okay.
Every day the medicine prices are rising, and you don't know that you are getting quality medicines or just a local homemade medicines wrapped in better packaging.
Okay, thank you, Dr. Bilal.
Thank you.
Back to Hasna. Thank you, Hasna.
Okay, doctor. So one of my friends sent me a private message.
Right.
So she asked me about which one doctor thinks that the best model for Indonesian healthcare.
Indonesia, I think Indonesia has also a mixed healthcare model in which some people are getting through out-of-pocket expense model as well, and there is a method Bismarck model as well, in which they are getting through taxation, and there is insurance system as well. Correct me if I'm wrong. I think Indonesia has a mixture of, just like Pakistan, Indonesia has a mixture of different models as well. So I'm sorry, what was the question? I missed it. What you want to answer? No?
What is the best model to implement it in Indonesia regarding the current situation in
Well,
healthcare?
actually, it depends upon so many things. For example, if I say the best model is that the population does not have to pay, don't need to pay any money for their health. So in that case, the government should be strong enough financially to afford the finances paid for the health for the huge population. So the country has to be strong enough financially to support the health of the population, right? But if the country is not strong enough financially, then the second model, which is called the taxation model or the insurance model, the Beveridge model or the Bismarck model, these two models are very relevant to Indonesia or any country, whether it is Indonesia, whether it is another country. These two models are highly relevant because in which they are asking some amount of money from the population, from the residents and citizens, rather than giving the huge responsibility to the government. So obviously, if the government is not strong enough financially, then it is better to take some money from the population as a additional money in the form of either taxation or insurance, and then provide them services. Obviously, out of pocket expense model is totally very against the population, because the population has to pay, and there are so many challenges and so many irregularities in out of pocket model that it has to be abandoned in everywhere from across the world. So this is what I think. The initial two model, my answer to that question is the Beveridge and the Bismarck model are the best for any country.
Okay, so instead of implementing a model from any country, we should make a model that fit into our population, right?
That can be, research is
Oh,
available.
that can be.
That
Okay,
can
okay.
be. For example, there are 4 models you can create, and if you are a social entrepreneur or a sociologist, you can develop a 5th model as well. And based on research and based on evidence, if you are good in financial plannings and things like that, and then you can propose a 5th model as well. That there is always a room for improvement. So if you are good in it, you can suggest a new, just like Beveridge or just like Bismarck has suggested their own models long time ago.
Okay, understand.
Right.
So Mrs. Aina Shofi.
Okay, thank you, Hasna, for the time. Thank you, Dr. Bial, for the explanation. I think that it was interesting because you already told about health information system and the another strategies in best practice was to leverage health information system. I'm curious about how health information system applied in Pakistan. I mean, what kind of maybe data integration or the use of health information system that applied in healthcare deliveries in Pakistan, and how about the response of the health workers and also the populations in Pakistan? Thank you.
Very relevant question. Thank you very much, Aina Shafi. I've been involved in recently hepatitis and HIV program in the national point of contact. So with the CDC and WHO, we have seen that there is a huge amount of prevalence of hepatitis in Pakistan, especially in several areas of the country. And we don't know the reason why suddenly there is a rise in prevalence. So the Minister of Health suddenly, told us that you should develop a proper implementation system and surveillance system as well. So we developed a surveillance system national level, initially provincial level and then national level. Based on that, we came to know. So there was no data collection method and proper dashboards in which we can easily identify that any positive HIV, if got married with some lady, then a child was born with HIV, and where they have migrated to which part of the city and which part of the country. So we don't know their own trail and actual movement across the country. So based on that, we did not know whether they are spreading the disease or not. So now we have introduced a proper dashboard surveillance system. Similarly, we have different dashboards which are existing, which are some rudimentary forms. We have recently developed a registry by the name of Life is Better, which is for vaccination, in which they give the specific QR codes to a child. And then based on that QR code, there is a data available for every vaccine the child has received. So we have different registries and we have different dashboards, national, government level as well as there are, in addition, different big hospitals like you might have heard the name of Aga Khan University. So Aga Khan University is a well-known across the globe. That university has their own extra amount of funding for the research. So they have their own separated slum areas where they do the research and they collect the data, and then they improve the health services over there. And they provide recommendations to the government that in these areas, this is needed. So big hospitals like Aga Khan, Indus Hospital, and Shaukat Khanum Hospital, these are the research hubs. So they have separated, integrated, and segregated areas of research, and they are collecting data on different specific domains from different areas. So there is actually the segregated research going on in different areas of country rather than not across the whole Pakistan. Yes, for vaccination, we have whole Pakistan registry. Yes, for hepatitis, we have a whole registry and dashboard for hepatitis and AIDS program, and mental health as well, recently introduced. So there are so many things which are working and which are still working as well.
Okay. Dr. Bilal, so if I may give a comment, maybe is that system have their different applications? Because in Indonesia itself, there's so many applications that made for like surveillance or data collecting, but that many application used is like giving more administrative burden for the health worker itself and does not really provide the adequate level of data depth for analysis. Is that problems also occur in Pakistan?
Yes, actually, those areas which do not have the proper data collection method, they face lack of research and lack of, evidence. But those areas which have a proper data collection method, where certain hospitals and research centers, they are working and collecting data, their analysis is available. So even, mix multiple indicator cluster survey mix is also, results are also available across the country for every province of Pakistan. UNICEF data is available for every province of Pakistan. WHO data is available for every, and how they are getting that data from segregated attempts across the country, not as a whole overall from the whole country. They are getting, WHO is getting segregated data, and then they pool it, and then they predict based on evidence and based on proportionate model that this could be the result overall for Pakistan. Actually, the result is from the certain areas only. That is the point.
Okay. Thank you for your explanation, Doctor.
Thank you. Thank you.
Okay, maybe lecturers or college student has more question for Dr. Siddiqui. It's okay to ask via message and use Indonesian language. I will translate it as I can.
Yes.
Okay, Dr. Siddiq. I think I will count down 3, 2, 1. So if there are no question more, maybe we can close the discussion and Q&A session. Maybe participant here has question in further time, in other time. So I'm sorry, I want to ask, is it okay, Dr. Siddiqui, to send an email to further us our collaboration through your email?
Yes, more than welcome anytime. But just send a reference that you're talking from this university, because so that I can understand that in context of this lecture.
Okay, oh my God, you're so kind. Thank you so much. So, ladies and gentlemen, so I close the discussion and Q&A session, and let me read the conclusion of this guest lecture. So health system encompasses all the organization, people and action whose primary intent is to promote, restore, or maintain health. Health system should contain 6 domains: service delivery, health workforce, health information system, medical products, vaccine, and technologies, health financing, also leadership and governance. Good health system is important in developing countries because not only create a good health outcomes like increasing life expectancy, but also has a positive impacts to economy like productive population, increasing equity, maintain SDGs, well prepared facing pandemics, and has a good data to analyze more. There are some models to maintain a good health system in every countries with its plus and minus, like Dr. Siddiq has explained before. So not only government, but also everyone has a role to make a good health with system in their country. For example, NGO, it play a critical role, especially in developing countries when government resources were limited. There were so many systemic and unsystemic problems in health sectors, such as lack of data, corruption in health, and the others that really requires policies improvements. We can also learn from countries that implemented a good integrated health service delivery model. And Dr. Siddiq said that the database is the most important, right? And the most important thing is improving health system and service delivery in developing countries requires well thought out policies and strategic direction that align with global health goals. Okay, before we close this event, we will take documentation together. Dr. Siddiq, is it okay?
Yes, yes, yes.
Okay, maybe the committee will take the photos. Are you ready?
Yes, yes.
Okay, let me count. But before it, please everyone to turn on the camera and join with us in documentation session. Okay, for the first slide, I let me count in 3, 2, 1. 3, 2, 1. Okay, the second slide. Let me count. 3, 2, 1. Okay, and the third slide. 3, 2, 1. Okay, because another slides is not open camera participants, so we end in the third slides only. Okay, thank you so much, Dr. Siddiqui, for your enlightening lecture and sharing your knowledge with us. We really appreciate your time and expertise. Thank you so much. Thank you so much, everyone, for your active participation. Hope that today's discussion has been informative and thought-provoking. I'm Hasna Amalia Salsabila. Wish you all a happy and productive day. See you next time in further collaborations. Wassalamualaikum warahmatullahi wabarakatuh.